Welcome to YHTV's Magical Medical Tour. This is episode 12. I'm Christina Suzama, and with me I have our brilliant medical guide, Dr. Glenn Wollman. Hello, Glenn. How are you today?
I am great, Christina, and greetings to everyone. Welcome to Magical Medical Tour. I'm Dr. Glenn Wollman, and I'll be your medical guide today as we travel through the healthcare galaxy, searching for optimal health. How was your weekend, Christina?
Oh, brilliant. Brilliant as usual.
Well,
The energies were strong, and we were working right through the weekend as per usual.
right.
You're going to tell me
Energy.
that's not healthy. I know that.
No, I think it's very healthy. In my past life in emergency medicine, I never even considered that there were weekends that existed.
Aha.
And and when you're in a residency program, you don't even know when seasons exist.
No.
I remember during one of my surgery rotations, I was on a rotation for about 3 months, and I would get there in the dark in the morning, and I would leave in the dark at night, and we were working in these operating room caves. And the only way we knew that it was something is someone would come in and say, "How was your Christmas?"
Oh,
then we then we would know that it was winter.
no. Wow.
Yeah, things like that. That was our cue to the outside world.
Well, now you're bringing the outside world to the people who are inside.
That's right. I think so. Today's a very special day. We're going to be talking about a very interesting topic, end of life and end of life care. And many of us don't want to face that, although we all end up facing it. Many times we end up facing it with a loved one first before we have our own. And I was doing a little bit of research, and I was looking up history of hospice and how hospice is termed in other countries and things like that. And in Taiwan, for example, the term for hospice is translated into peaceful care.
Hmm,
And
lovely.
then, yeah, it is lovely. And then in Hong Kong, they didn't even actually have a word for it for a long time because the culture was that you took care of anyone that
Yes,
was sick. You kept them in the house.
yes.
So they have a word for that, and I don't think I would try to say it, but the translation or the simple translation means well ending service.
Mm,
And it takes special, very special people to go into this because of the entire process. And my guest today is Dr. Michael Bordofsky, who is one of those very special people who branched out from his career in internal medicine as an internist and works as the director, the medical director of the Santa Barbara Hospice and Palliative Care Institute.
mm.
So I would like to take this moment and introduce my good friend and colleague, Michael Bordofsky. Greetings, Michael.
Hi, Glenn. How are
Hello,
you?
Michael.
Good morning.
I'm doing well, and you've met Christina now.
I have.
Excellent. So, usually, just to let me set the stage for you, Michael, as the medical guide, I usually try to give our audience an idea of the path that we're going to take today. So, what I usually like to do is start out and talk with you a little bit about your own personal journey, how you got into medicine, what interested in you in medicine, when, why, how, where, all of that, and why you chose to be an internist, and then how you made the shift into hospice and palliative care. And then we'll go into what hospice and palliative care are. And then we'll talk about some practical aspects that I think people really need to know. And at the end, we'll hopefully end with a health tip from you to guide us all towards optimal health. How does that sound to you?
That sounds good.
Okay, so let's get started here. I'd like to know, and the audience would like to know, give us a little bit of your journey.
So, first, I'm not one of these people who knew they wanted to go into medicine from the time they were in, grade school. Um, but my mom is a nurse, and she didn't work as a nurse in a hospital setting, at least when I was growing up, but she worked as a Lamaze teacher for many years. So I would have grew up having these couples come to our house with their pillows in hand. So I was exposed to kind of an interesting side of healthcare throughout my youth. But I didn't really plan on going into medicine. I didn't know what I was going to do, but I ended up, in college, and I was a science major, and I got good grades. And when I was in college, if you were a science or biology major and you got good grades, then medical school was what you looked at and aspired to. So that's kind of how I ended up going into medicine. So it wasn't some kind of burning interest or passion of mine at the time. But I went on to medical school. Of course, my mother, who was a nurse, was quite happy about that, and went to medical school in San Diego. And then I was married and had my first child right at the end of medical school, and had to make decisions about both where we wanted to live and what specialty to go into. And my wife and I are both from Santa Barbara, and we decided to try to come back here. And to do that here, they had an internal medicine and a surgery program in town, and I chose to do internal medicine.
Nice. So you practiced internal medicine for a while and still practice it, in fact, correct?
I do. Spend about half my time doing general internal medicine. So I'm, a primary care provider to adults with things like, as mundane as high blood pressure and diabetes, and doing wellness checkups. Then the other half of my time, I work in hospice and palliative medicine.
And what was it that took you there? First of all, it's a pretty new field. I mean, it's been around for maybe many centuries. Around, my research says, the 11th century to some level, but in this country, it's only been relatively recent in terms of joining the healthcare process.
Mm-hmm.
What made you recognize that, see the need for it, and what drew you to it?
Again, I sort of fell into it almost, I won't say accidentally, but almost in an accidental way. And it's a little bit of a story. Do we have time for me to tell you the story of how that happened?
I think so. I'll stop you
Okay.
if I've heard the story.
Okay. So,
but I haven't heard it.
So,
Christina would probably also say there are no accidents.
Yeah. Well, you'll probably reinforce that when I tell you this. And yeah, Christina, you'll probably like this story, I'm guessing. But so I was a medical resident at Cottage Hospital here in Santa Barbara. And at the end of my internship year, my first year of training, one of the other residents who was leaving the program came up to me and said, "Mike, I've got this patient, and I'm hoping you'll take over for me, because I'm leaving, and I want to make sure she doesn't fall through the cracks. And will you see her at the county clinic?" And we had an outpatient half-day clinic that we each attended. And so I agreed to take this patient. Her name was Anne, and she was in her mid-40s and had metastatic cervical cancer. So, advanced cancer, and she was past the point where she could receive curative treatment. She was in that phase where she was getting hospice care and comfort-focused treatment. And so Anne would come to see me in the outpatient clinic on every 2 or 3 weeks. And she would come in to see me, and she was a pleasant woman, and I liked her, but I didn't really feel like I was doing much for her, because there were no more, chemotherapies to give her. There were no drugs to give her. There was just, talk and pain management to do for her. But she, for reasons at the time that I didn't really have a good grasp of, she kept coming back to the clinic, and she wanted to see a doctor and wanted to have that connection. But as she got sicker, she got to the point where she couldn't come into the clinic. And the whole time I was getting these calls from this hospice nurse who was looking after her in between our visits. And when this hospice nurse would call, she would say things to me like, Dr. Bordofsky, Anne's having more pain. Don't you think we should increase her pain medicines a little bit? And, I wasn't real knowledgeable back then, but I knew enough to know when I was speaking to someone who knew more than I did. And so I would say, sure, yeah, that's exactly what I was thinking. We should, adjust her morphine dose. And so this hospice nurse kind of led me through, guided me through the care of this patient. And when she got to the point where she couldn't come into the office anymore, after a few of these phone calls, I said to the nurse, I said, I'm getting a little bit uncomfortable with this now because I haven't seen Anne in several weeks. And, we're prescribing controlled substances, and I just don't know if this is right. It seems like, it's not right for me to keep doing these things if she can't come in to see me. And the hospice nurse said to me on the phone, she said kind of very calmly, she said, well, Dr. Bordofsky, you could make a house call. And this, of course, hadn't occurred to me at the time that I could do that. But
that wasn't part of your residency training?
It wasn't part of the residency training. But I went to my supervisor and said, I've got this hospice patient who can't come into the office now. And the nurse said, maybe I should do a house call. Is that okay? And he said, sure, go ahead and do that. So from that point forward, I started making house calls to see Anne. And she was a mother. She had 2 teenage sons, and she was living in her parents' house at the time. And they were kind of her main caregivers. And so I would go out to see her every week or two. And again, it was kind of the same thing. I would go see her. Felt like, gosh, I'm not really sure what I'm doing here, and I don't really feel like I'm doing a whole lot, but she wants me to keep coming back. So I did that, and, I established, a nice relationship and rapport with her family, and found it surprisingly enjoyable to take care of and be with this woman who was dying. And then one day I got the call that she had passed away. And I remember it was on a Saturday morning. And as Glenn, as you know, the interns and residents in the hospital are the ones who are responsible for going and pronouncing patients when they die. So typically, if somebody dies in the hospital, the intern will go to the patient's bedside and listen to their heart and write down the time of death. And I didn't realize that wasn't something that you had to do outside with the death that happens outside of the hospital. So when the nurse called me and said that Anne had passed away, I said, okay, well, I'll go out and pronounce her. And I think I wanted some closure myself at the time. So as I'm driving down the freeway to get to her house to go see her and see her family, it had been kind of a rainy morning, and I look up over the freeway, and there's this giant rainbow spanning the freeway and coming down in her neighborhood, it appeared. And, I'm driving along looking at this and saying, I don't really believe in these things. Come on, that's not, that can't be real. But I'm pretty sure it wasn't a hallucination. And I got to her house, and I pronounced her, and I visited with her family and gave my condolences to them. And really had what was probably certainly the most memorable experience of my whole medical training. And when I finished my training a couple years later, there happened to be an opening in the hospice. They needed a new medical director. And that same supervisor who had given me permission to make that hospice visit recommended to them that they interview me and consider me for that job, which they did, and I got the job and took the job, and that was about 17 years ago or so, and I've been working with the hospice team and ever since. So it was a very memorable story. It was almost like my sort of pot of gold at the end was at the end of that rainbow, and it's become a very fulfilling and meaningful part of my work.
What a beautiful story. Thank you so much for sharing that, Michael. And yeah, isn't that great? The other side of the rainbow.
Yeah.
Those
You know,
so-called illusions.
I was going to say the exact same words. What a beautiful story, but I had a feeling that you may say something, Christina, and I'm glad I waited because it sounded so nice listening to you say it rather than me. And thank you for sharing that. It clearly was profound and memorable for you because you remember such wonderful details of
Mhm.
that. So, in your mind, was it an accident?
Um, uh, I don't think. I mean, I think in my mind, rainbows are a phenomenon of nature, and I
Hmm.
recognize them as that. I don't think it's an accident that I ended up in, working in this field. I think I was probably drawn to it, and you create your own experiences. I think.
Hmm. So, I think it would be a good idea for us to know a definition of hospice and maybe differentiate it between hospice and palliative care. What are the similarities? What are different about them? Can
Sure.
you?
Sure. Well, hospice gets defined, variably. In a lot of ways, hospice is sort of a philosophy of care. It's a philosophy about affirming life, recognizing dying as part of the natural process of life. Hospice focuses on family and the family and friend relationship to the person who's dying, and recognizes that it's not an experience that just an individual has, but that a family and a group has together. Um, and then hospice recognizes that an important part of care for people who are at that point in their life is attending to kind of the psychological and social and spiritual needs of patients and families. So in that way, it's sort of a philosophy of care. That philosophy of care, though, has been translated into models of care in this country. So hospice is also a model of care. It can be a place, so people can go to a hospice home or a hospice facility where they get that model of care. So that's another definition of what a hospice could be, which would be basically a place for the dying to go to where they're kept comfortable and cared for. And it's also a program, or it's an insurance uh, paid for benefit for most people who have medical insurance and everybody who has Medicare. In fact, Medicare's adoption of hospice and recognition about 20 to 25 years ago that it was a valuable part of the medical spectrum is really what accelerated hospice growth in this country. Um, so Medicare said, we think this is valuable. We should cover that as part of people's health care. People had access to excellent hospice care. Programs grew incredibly throughout this country in the 1980s and the 1990s. And it became so successful. People said, "Wow, this hospice stuff is great. It's too bad you have to be at home to get it, because hospice was a home-based service. It's too bad for all these people dying in the hospital or sick in the hospital that they can't get good access to these teams of doctors and nurses and volunteers to take care of them in the hospital too." And so out of that grew palliative care in this country. So palliative care was the answer to that question. What can we do to bring this model of care into the acute care setting and expand it beyond just people who are at the very end of their life, but also include people who have, a serious illness but aren't necessarily dying or may still be expecting to recover. So we started with hospice as a home care model for people who are dying. And then in the last 10 years, there's just been an incredible growth of palliative care, which is done, at least initially, in hospital settings, not just for people who are dying, but for people who are facing a serious illness, so they can get good quality symptom management and good support as they're going through that. And then the latest thing that's happening now is people are saying, "Wow, this palliative care stuff is great. Um, it's too bad you have to be in a hospital to get that." So it's kind of come full circle, and people are now saying, "Well, we've got hospice care for people who are at home who are dying, We have palliative care for people in the hospital who are either, going to die in the hospital or who just are pretty sick and could use that extra layer of support. And now they're saying we should have palliative care in the community setting for people who aren't necessarily needing hospice care, but still need symptom management and support. So that's sort of the latest movement is clinic-based and outpatient-based palliative care programs.
Hmm. What do you see in the future for hospice? How is it going to evolve even more?
Well, I mean that's a really good question because hospice and palliative medicine have like I said, really grown incredibly. And we're really being looked at as one of the components of um, trying to help improve the healthcare system in this country because we're team based, we're value focused in terms of focusing on what patients really want most themselves. So focusing on comfort and quality of life. And so people are, on the one hand, looking towards hospice and palliative care and saying, this is what we need more of in our healthcare system, these types of models of care. But then on the other hand, we sort of got kicked in the stomach with the healthcare reform issue when that was being debated and passed in 2010, I believe it was now, where some people were saying, yeah, we need to provide more hospice and palliative care to people. And then a certain governor got on her Twitter account and tweeted something about palliative care and hospice being equivalent of death panels. And so all of that part of the healthcare reform was kind of stripped out and taken out of the healthcare reform budget. Yeah. And we really needed it because we're sort of running out of doctors and nurses to do palliative care and hospice care. So we need training programs. We need more research in the field so that we can kind of improve our scientific basis for care. And so we really need that kind of support from our national healthcare programs and stuff. And this was kind of a setback for us. But we're so hospice and palliative medicine. There's so much demand for it, and patients are just really happy and satisfied when they get care from our hospice teams and our palliative care teams. So we're a resilient group, and I think our future in healthcare is going to be really a prominent one. But we've got to get past some being used and manipulated by certain cynical politicians.
It always comes down to politics, isn't it?
Yeah, that's always there in the background.
Yeah. That's pretty amazing. I just being from Canada, I wasn't very familiar with the healthcare system here in the U.S. The only thing that I always think of is necessary, have insurance. But recently last year, I had taken in a 91-year-old uncle who was told that he was going to die in about 2 to 3 weeks. And I took him into my home because he had no children, etc. And I was immersed suddenly into, I guess you call it Kaiser PPO, or I don't know how you.
Yeah, they're I think sort of an HMO model, but
is it HMO?
Pretty evolved one, yeah.
You see, now that I've stepped away from it, I can't remember the PPOs and HMOs anymore. But luckily, they had a wonderful palliative hospice care group that worked so brilliantly. I mean, really, really lovely, very well organized, very well orchestrated, lovely doctors, lovely nurses, all the way down to the people who would come and shower him. And it was my first introduction. I've always cared for elders or people who have been in transition with cancer and things like that, and sort of, walk them through those steps. And in the world that I work in, in their transition, from one place to the next. And I always find such joy in that, to just see, as Glenn, that wonderful statement that you made about how they say it in Taiwan, that peaceful exit or that peaceful ending. That's to me the brilliance of seeing someone go so gracefully and help guide them through and support them through that. And having suddenly immersed myself with this team of doctors and nurses who deal with hospice that I had no idea of, in palliative care, because I come from more of the Asian background where you support whomever it is right till the end, pretty simple. And to know that there was this whole other entity out there was so brilliant. And I so commend your work and really honor your work that you do and the gifts that you give to so many, because it's ending or any kind of change like that is so frightening to most people that even the Chinese culture, as if you're familiar with it, you don't talk about death at all. You don't mention it. You don't use the number 4 in anything because it signifies death because of the sound and the tone of the number 4. So it's completely avoided. You don't to say to somebody that you wish death upon them is like a curse that they will never forget. So to have such a core of support for people who are in that sort of fear is absolutely brilliant, really brilliant. And I hope that the powers that be, whether it be politics or anything like that, will really start to recognize how important this is for all of us, in our future.
I remember in keeping our licenses current a few years ago, usually it was just a requirement to go and get CEUs or continuing education units in whatever our specialty was. But suddenly they added that in order to renew our licenses, we had to have some hours of training in end-of-life care and pain management. So speaking of that, what kind of training do the nurses go through and doctors that want to be in hospice and palliative care medicine go through?
So back when I started, it was all on-the-job training, and you learn by reading and going to conferences. In fact, when I was in medical school, the main textbook of medicine, Harrison's textbook of medicine, which weighs like 10 pounds, and it's 1,000 plus pages. I looked up one time to see, well, what are they actually saying there about caring for dying patients? And they actually had, it was less than 1 page. It was 15 inches of text in the old Harrison's textbook. So, I mean, and that sort of, epitomizes the lack of attention that was given toward, things like pain management and end-of-life care back then. But things have really evolved a lot since then. So now, instead of, there are whole classes that medical students take. They do hospice rotations. There are entire 10-pound textbooks of palliative medicine that are entirely filled with information about how to take care of patients at the end of life, how to do symptom management. They've got chapters on every possible uncomfortable symptom that a person could have and how to support people through that. And so it's really evolved. So when I learned palliative medicine and hospice medicine by reading, going to conferences, and by the seat of my pants, just on the job training. But now, if you want to get specialized in hospice and palliative medicine, they actually have fellowship training, just like you could, you finish your residency and you could go do a cardiology fellowship, for instance. You can go and do a palliative medicine fellowship. So that the training is formalized. It's an officially recognized subspecialty board certification. And so people who want to learn more and actually want to work in the field now are really, it's necessary to go and do fellowship training now. This is the last year that people can actually be kind of grandfathered into the field just based on their experience and get board certification. But like I said before, it creates a little bit of a problem because there aren't enough fellowship programs to really train the leadership, the workforce that we need in the field. for nurses and social workers and chaplains who work in palliative medicine, there are also other variable training programs and levels of certification that people can get. We do a lot of education and training just locally here to get our colleagues and our nursing staff up to speed on some of the new stuff in hospice and palliative medicine as well.
A question for you. What about the families? I mean, is there a support system for the families who are the caretakers of these patients as well?
Sure. Yeah. So, I mean, the thing that's different about practicing in a hospice setting compared to just the regular traditional medical setting, in the traditional medical setting, we're really focused on that person right in front of us, that patient, and what their immediate needs are. In a hospice setting, we look at the family as the unit of care, not just the individual person. So there's a lot of support for families. We realize that a single individual doctor or nurse isn't able to meet all of the broad range of needs that a patient and family have at the end of their lives. So we kind of travel in packs. We work in team fashion, what we call a multidisciplinary team. So we have physicians, nurses, social workers, chaplains or spiritual counselors, we call them, volunteers, pharmacists, nursing aides. We all meet on a regular basis to discuss cases, and we put in whatever supports are necessary for a family and patient to make sure that they can take care of their loved one and be comfortable doing that and have the support they need. So in a hospice setting, that means nurses will go out in the middle of the night and take care of somebody who's having symptoms and doesn't want to go back to the hospital, but wants to be taken care of in their home. For families, it means that the care doesn't even stop at the time of the person's death. There's a bereavement period that goes on for 13 months after death, where people continue to get contact and support from that hospice, so that they're not having to go through those tough months on their own.
Oh, that's wonderful. And this is all through the hospital, or is this through your organization?
Well, no, this is through, I'm talking kind of generically about hospice programs. So if, anybody who lives in the U.S. and certainly in most of the Western countries, in fact, hospice is even a lot more developed in places like the UK and Canada than it is in the U.S. But if you get involved with a hospice program for your care, those are the kind of services that you're going to get, and that's out in the community. Again, in the U.S., it's part of people's insurance and Medicare benefit that this is all paid for, and that those teams of supportive practitioners are out there for people.
Oh, wonderful.
Michael, they have hospice, as you said, in the UK and Canada, and I know they now are starting hospice programs in India and Japan and other parts of Asia. Do you meet with hospice leaders from around the world to see if there are things that can be added from other programs due to their cultures, ways of looking at the end of life that might be beneficial that we're not doing here? And in that same respect, do you use any integrative therapies in programs like acupuncture or massage therapy or anything else for your care?
Yeah, so in our hospice, we do have integrative therapies, and we have people who give Reiki, and sometimes patients are getting acupuncture and aromatherapy, and it's all about what the patient, the family's needs are, and what their personal desires are. There are families who are really into that, and that's what they want. And that's what they get, strength and comfort from. And so we try to do the best we can to facilitate those kinds of things. I don't personally myself practice those integrative therapies. I consider myself well versed in Western medicine and have a hard enough time trying to do that well. But we certainly are hospice and palliative care programs I think are quite open to using integrative therapies. In terms of the other question you asked about kind of the international part of it, I think on an individual basis, a lot of the leaders in palliative medicine and hospice are really interested in how other cultures deal with death and dying and take care of people that at the end of their lives. Remember, and this is something that's not new. People have been dying and taking care of their loved ones as long as there have been people. So we have a lot to learn. But at an organizational level, the biggest challenges internationally are actually in some of the underdeveloped countries where they don't even have access to kind of basic things like basic pain medicine for somebody who's dying. And even in some of the somewhat developed countries, I heard a presentation recently from somebody who was practicing in Eastern Europe. The restrictions on using opioid pain medicines, for instance, even for people who are dying, are really quite onerous. So on an international basis, the issues are really kind of quite basic right now. Just trying to get people kind of the bare bones of comfort management as a starting point. And so there's a lot of people in the U.S. hospice and palliative care and in the U.K. and Canadian hospice and palliative care arenas who are trying to advocate and help out in other countries to create access to these types of things.
Let's get down to the nitty-gritty for a few minutes here. You talked before about people that have insurance that can have hospice care. Can someone without insurance get hospice care?
Sure. Yeah. I mean, I can't speak for the entire country, but for instance, in our community, I think most hospices function this way. We're there to serve, and we don't get in the way of people getting hospice services, regardless of whether they can pay or have an insurance company to pay for it or not. So we take all comers basically who need and want hospice care. Most hospices do require that a physician be agreeable to making that referral. So that can sometimes be a barrier for people, for a family who wants their loved one referred for hospice care and the physician feels like it's not the right time yet. So that's an area where there's often kind of some negotiation between a family and a physician on kind of that nitty-gritty level. Some of it has to do with just recognition of, how do you know when somebody's actually getting near the end of their life, and when you've done enough, testing and treatments or not. And those have to be looked at individually, I think.
How does someone make their own determination that they want hospice? And this can, again, be, I think the categories are someone that's dying, someone that's grieving, or a caregiver, all of those different categories. What makes them think about hospice?
Well, I mean, the typical situation is a person who's got a serious illness and who has arrived at the point where either there are no additional curative treatments that are likely to work, or they've arrived at the point where maybe there still are some things that a doctor might want to try that might cure, but the patient themselves is saying, I've had enough, and I really want my focus to be on comfort care and not life prolongation. So those are kind of the typical symptoms. Areas where it gets a little harder to tell are say somebody like Christina's uncle, or in Christina's uncle's age group, maybe somebody who has Alzheimer's disease, for instance, and can't really speak for themselves, and they've had a slow deterioration over 5 or 10 years. And how do you know when the right time for thinking about hospice care would be for that person? Mm-hmm. And so those ones we struggle a little bit more with.
One of the issues that always comes up for me are the families that say, well, my loved one is dying and we want to put him in hospice, and then when something really goes wrong, they suddenly want treatment again. Say a pneumonia that comes up, and how does hospice deal with things like that and prepare people for that process?
Yeah, so in patients who are actually enrolled hospice patients, we put emergency medicine kits in their homes, and we have 24-hour access to nursing care. So for that family who's taking care of a loved one who, maybe gets sick, in the middle of the night, and they really don't want to have to take them back to the emergency room, they now have options. They've got medications in the home that can be used for comfort management. They've got a nurse available who can come out, within, a matter of an hour to help get them comfortable and keep them comfortable at home. And that's how, for most of our hospice patients, we're able to facilitate a comfortable, dignified death in the home. I think, Glenn, what you probably saw a lot in the emergency room were, people who were kind of frail, the frail elderly or the chronically ill person who's sort of decided, they don't want any more aggressive treatment. But then when they get sick in the middle of the night, there's nobody to call. There's no support. It may take them 2 or 3 days to get in to see their physician. And so what options do they have? I mean, they end up having to, they're sick and there's nobody to call and no other way to get help. So they call, an ambulance and they show up in the emergency room. So hospice is really, in one way, one of the benefits that we provide is the creation of an alternative emergency plan, some other options that you'll have, when your loved one gets sick or when you get sick.
Mm-hmm. Michael, I found that there was, maybe you can help me understand this better, seemed to have been a very fine line between hospice and palliative, because I know you described it earlier, but what I found to be very curious was my uncle, whom was supposed to die in 2 or 3 weeks, actually didn't end up dying. Mm-hmm. He ended up living for another, I do believe, almost 9 months, actually. So, and got pretty strong. So he was sort of, there was that balance of when he was considered out of hospice and into palliative. And it was something that we never really got to sort of clarify those lines on.
Right. So this is kind of, it's definitely a common source of confusion is, what's the difference between hospice care and palliative care and who should have which one? And hospice care is in this country, as it was sort of defined by the Medicare benefit, they said, we're willing to pay for hospice care for Medicare recipients who have a 6-month or less life expectancy, which sounds great on paper, but actually figuring out who has a 6-month or less life expectancy is really difficult. And it's obviously, inaccurate a lot of the time, and there's a lot of guesswork involved. So for our hospice patients, if they live longer than 6 months while they're on hospice, they're actually allowed to continue to stay on hospice as long as it looks like they still have that limited prognosis. So we sometimes have patients on hospice care for more than a year even, because they exceeded what our expectations were in terms of how long they'd survive, but they're still deteriorating in that time. But then we also have patients who really truly get better. Sometimes it's just all the TLC and attention that they get on a hospice program seems to help kind of pull them back from the precipice. So we graduate and discharge a fair number of patients from our hospice program also.
Oh, wonderful.
And for those patients, we try to get them connected with other services in the community. So that's where if you live in a community that's got an outpatient palliative care service, where that might come into play, after you've graduated from hospice. Or palliative care, again, doesn't have that restriction on just being for people who are dying. So, for instance, there's really a big push now to get palliative care for cancer patients who are going through treatment, even if you think they might be cured or they're going to live for, another 5 years. Some of the big important papers published last year showed that people with lung cancer who got palliative care early in the course of their treatment actually lived longer and were more comfortable. They had less symptoms, less pain, and less depression, and it improved their survival. So there's a real push to get palliative care, palliative medicine, moved upstream, so that it's not just for somebody who's in the dying stage, but it's for people who have a serious illness and that level of need.
That would be wonderful. That'd be really great.
I just got an email from a person asking, they're working with an elderly person that they believe is dying, and they wanted to know if it was okay or it was bad to tell them that it was okay for them to go home or be allowed to die. Does hospice give training to families? You talked about families. Do they help them in having discussions with the dying members?
Yeah, absolutely. And a lot of what we're there for is to give support to families and answer questions, just like that. What do you say? How do you talk to the person? When is the right time to be discussing it? And every family and every situation is different, and so that's why you can't just kind of put up on a website, here's the time to tell somebody when they're dying and when to go toward the light. Life doesn't work like that. But if you have somebody who's actually out in the home, who knows the family, knows the patient, knows the situation, then they can give, good advice and good counseling to people.
I'm gonna go out on a limb here for a moment and ask a question. Not in our state, but in other states, they approve of assisted euthanasia or assisted suicide. Is that something that hospice will ever be part of? Do you see anything in there?
Yeah, interesting question. I mean, if you ask the lay public, most people probably assume that hospices are big advocates for physician-assisted suicide or euthanasia, those kind of things. But actually, traditionally, hospices have kind of taken a position against legalizing physician-assisted suicide. And the reason for that, I think, is that when you actually get out there and you work with patients who are dying and people who are dying, you find that it's a very, very small minority of people who actually really want and need help to speed up their death. What most people need is they need good end-of-life care. They need good symptom management and good support in those settings, and then they don't ask you about, or they're not talking about how do I speed up my death. So traditionally, hospices haven't been real enthusiastic about efforts to legalize physician-assisted suicide, because we think what we really need are more efforts to improve end-of-life care for everybody. Having said that, there's a really broad spectrum of opinion among people who work in the hospice and palliative medicine field about that. There's a very slow movement of states to legalizing physician-assisted suicide. I think it's being looked at in Montana now, and right now the only other states where it's legal are Oregon and Washington, I believe. But it's a controversial area. It probably doesn't. It's not something that the majority of people really need, but it is an area that many people are interested in.
What's been the most difficult part for you, either on a personal level? I mean, you're seeing people dying every day, and I know people that have worked in hospice, and after a certain amount, they started as volunteers and realized that they just couldn't handle it. So it is a very special person that goes into this. What's been the most difficult part for you in this whole process?
I think it's difficult for people who struggle with creation of their boundaries. So I think people who have difficulty, knowing the difference between being a professional person caring for a patient and being somebody who's sort of personally and highly emotionally involved with a patient, they're going to struggle in hospice and palliative medicine, and they don't, they often can work in that area and do great work for a few years, but then have to go on to something else, because it can be too kind of emotionally exhausting with multiple losses as you take care of that many people who are at the end of their lives. But people who have a good kind of I don't know how to describe it, but kind of balance and know what their limits are and are introspective. They can last a long time in hospice and palliative medicine. It's really, people are always saying, when they hear you work in hospice or something like that, their first comments usually are, oh wow, that must be really depressing work. But it's actually really it's very rewarding. You're there with patients and families at a time in their lives when you can really make a big difference that matters to people, and it's you're invited into what's a really kind of an intimate time in a family's life also, and to be able to be there and witness that and play your part in that is actually quite rewarding. So the the risk of burnout for professional providers in hospice and palliative medicine probably isn't much higher than it is in any other medical field, and in some ways it may be less so.
I was thinking in my mind when you were asking that question, between someone like you, Glenn, who was working in the emergency department, running around like as you said, speed, quick movements were the key, to someone in hospice, which is about the calm, the flow,
Yeah.
I don't know. I think the burnout would be where you're at.
Well, there is a lot of burnout in certainly in emergency medicine. But again, I think in people that go into emergency medicine, some go in for it because of the lifestyle that it leads to or allows. Some go in because they really love that concept of medicine, and those that really love it, there's usually not burnout when you're practicing the medicine, as in many of the other fields, as Michael will surely attest. It's the paperwork and the administrative things that seem to cause a lot more of the burnout. I find that most doctors and nurses and healers go into their professions just because they will get joy out of healing and helping in healing processes. And even dying is a healing process in many ways, I think.
Mm-hmm.
Yeah, I agree.
Yes.
Michael, go ahead, Christina.
There was a question that came in, Michael. Where is the best place to take care of an elderly patient when they're in a lot of pain?
Well, I mean, I think that's a perfect situation where you want to, go to your doctor and say, is this, a situation where we could get help from a hospice or somebody in palliative medicine to try to help with pain management. But, in those situations, that's with especially with an elderly patient, you really need an advocate. And so somebody who can stand up and call up or go to an appointment with them and say, look, my mom is really uncomfortable. She can't sleep at night. Really just be able to describe what the problem is and insist that there be some focus on that. When you're taking care of elderly patients, they have such long lists of medical problems and long lists of medications, and they're really complicated patients to take care of. And if they can't speak well for themselves, they really need somebody to be there with them when they interact with the medical system to focus the professional's attention on the right places. And so if it's pain, then going with them to a doctor's visit or calling up and saying, look, this is what we need to focus on, and insisting that you get that kind of care.
Thank you.
Michael, with all of my guests, I always ask for a special health tip based on your own unique experiences in medicine. Can you share something with us today?
Sure. So I was thinking about this, and I thought it probably should be relevant, a health tip relevant to what we've been talking about here today. And I just want to share with you kind of one of the things that I've learned over the years. Everybody wants to be comfortable at the end of their life and avoid suffering and have what some people describe as a good, dignified, peaceful death. And I think the thing that you might assume about that is that it's dependent on what you die from and what disease you have, and that you have enough morphine at your bedside is going to ensure that you're comfortable. And that's actually how a lot of medical people come at that also. But this has actually been looked at, and it turns out that the amount of distress and suffering that people have at the end of their life is really highly correlated with how they lived their life, and not as highly correlated with what they're actually dying from. And so there's things written about the lowering and the lower correlation of suffering and distress at the end of their life in people who have what's termed healing connections. And so healing connections are sort of what my tip are, and I'll tell you what those are, or how they've been defined. But they basically talk about 4 broad categories of healing connections, and if somebody has a strong healing connection in one of these 4 categories, they seem to have less distress at the end of their life. So the categories they refer to, probably the easiest one to understand is family. So people who have a strong family connection, for reasons that we don't really understand, seem to have less distress and suffering at the end of their life. But it doesn't have to be a family connection. It can be any one of these. So another one is people who have connections, a strong connection with the natural world. So people who have a sense of being part of nature or belonging in nature, or just the beauty of nature, seem to have less distress at the end of their lives. Another one is a sense of self, and that one's kind of harder to understand or define, but I sort of think of it as people who are comfortable with themselves, who are introspective, who've thought about their lives and have some perspective on who they are in the universe, seem to have more comfort at the end of their lives as well. And then the other one is, of course, in the spiritual realm. So people who have a strong sense of spirituality or connection with their spirituality. Doesn't necessarily mean people who are highly religious, but people who have a strong sense of spirituality seem to have less distress at the end of their life. So those 4 healing connections, family, one's connection with nature, connections with oneself, or spirituality, whatever one of those things appeal to you as an individual, I think is part of our life work. We need to kind of foster those connections and really focus on that. If you want to have comfort at the end of your life and not be distressed at the end of your life, focusing on making connections in the world, regardless of what area it's in, really seems to be part of the secret.
Wonderful.
I think that's a fabulous health tip.
Ah. So go for one of the 4, everyone.
Yeah, and I saw that in the emergency department quite often when certain people were dying and there was no other alternative to the process, no matter what we were going to do, but they were still somewhat alert and oriented and conscious. The ones that had one of those 4 things, and spirituality seemed to be the easiest one to recognize in them, they seem to be much more peaceful in the whole process, along with the families and loved ones around the bedside with them. So that's a fantastic tip. Is there anything you want to end with, Michael?
I think you guys have asked really good questions, and it's been a pleasure to talk with you. And people who want to learn more, there's a ton of resources on the web now, and there are hospices in every community in this country and in most places around the world now. So there's lots of places to learn more and hear more, and hopefully people will find what they need.
Absolutely. And I'd like to let everyone know that we can learn a little bit more about Michael and his incredible team and their work at the URL palliativecareconsultants.com. palliativecareconsultants.com. It's a beautiful site that is, what I learned today, that is very new, and the amount of resources on that site is absolutely brilliant. And I can only see it growing even further and larger. So congratulations on that, Michael, and on all the work that you do and your team.
Thank you.
I'm very grateful to my special guest, Dr. Michael Bordofsky taking time and sharing his wisdom and expertise with us. I'd also like to thank my own teachers and all those that have healed me in my journey. I'm looking forward to getting together with all of you and Christina next time as we go through the other quadrants of the healthcare galaxy, searching for good things. And until that time, I wish you all optimal health.
Bye. Blessings to all.